have been so many stories about Nigeria being the highest carrier of the burden of sickle cell disease. I'm curious to know what's the parameters being used, and then why is it that Nigeria carries the largest burden globally in terms of sickle cell disease?
Yes, in fact, the new terminology I've seen that I even like is that Nigeria is the sickle cell capital of the world. In the whole world, Nigeria has the highest burden. It used to be said that it was considered a Black person's disease or Black people's disorder. You probably heard that yourself. But but I think that's it's somewhat obsolete now because epidemiology, the study of disease, how this disease is distributed around the world, indicates that it's everywhere in the world, it's all over. However, Nigeria does have the highest burden. Still, it's important to note that anywhere you have, if you look at the malaria map of the world, and you look at sickle cell map of the world, and superimpose them, they're one and the same. So wherever you have malaria, and that's across the tropics, from West Africa, from far part of West Africa, Senegal, down through Sierra Leone, Liberia, Ghana, Nigeria, across Central Africa, South African Republic, Cameroon, South African Republic, to East Africa, and even beyond to the Arabian Peninsula, to the Asian subcontinent, farther east towards, as far as what we call the Indonesian archipelago, those islands of Indonesia, you have sickle cell. So sickle cell is across. But what's common amongst all these places, geographical distribution, is malaria. It's malaria that we share in common. So it's not really a Black man's disease. Incidentally, I was at a meeting in Europe very recently, and there was a white man, not like you and I, like this Oyibo white man, he has a white wife, and he's from the Scandinavian countries, where people who are blonde and blue-eyed. Their daughter has sickle cell. And I came back and I reported it to the hematologists and epidemiologists here to say they need to really look at this and study that family, because there's no malaria in the Scandinavian countries. I've told you now about how we look at malaria in epidemiology. Malaria and sickle cell are one and the same. There's no malaria up there. Because even in Africa, in Southern Africa, you won't get sickle cell, except for those who have emigrated, who have traveled there. Because again, that's another thing that has changing the pattern of sickle cell in the world, migration and immigration. There are parts of the world now, in Canada, they're talking about sickle cell a lot, and it's Nigerians in Canada. In far down under Australia and New Zealand, they're getting sickle cell. But if you look at them, the population is Nigerians that are there. Nigerians are traveling everywhere in the world, and they're carrying with them the epidemiology. They're carrying with them the pattern of disease, okay? However, this is a long story. It's good to have a background. Having said that, Nigeria remains the capital of sickle cell disorder in the world. In terms of numbers, we talk about estimates because, it's a chronic condition. It's not the kind of disease that you say you can count, like cholera. Let's count how many people are having this disease. You can diagnose it and count it from place to place. It's not like that. So we do talk about estimates. So you can go to the community now and quickly do an assessment and make a determination of how many people have sickle cell. So we talk about estimates of how many children are born with sickle cell. We say 150,000 babies are born in Nigeria every year with sickle cell disorder. And out of this 150,000, we lose more than 100,000 of them every year. They die from infection mostly before the age of 5. Before the age of 5, we lose them, not every year, yes, we lose them before they turn 5 years old. The way it's captured in literature is that not up to 100,000 of them live to celebrate their 5th birthday. So it's not a good story. It's not a nice story. We want to change it as much as possible in terms of prevention, in terms of treatment, and now in terms of cure. That's where we are now, where we can boast and say that Nigeria has established a center that's state-of-the-art, where we can provide quality and safe transplant, bone marrow transplant, and that's the established cure for sickle cell that we have in the world today. There are other experimental treatments, experimental cures, but they're not established and they're not globally recognized. But bone marrow transplant is a globally recognized and established cure for sickle cell. And Sickle Cell Foundation Nigeria has given that to you today, to Nigeria?
Like you said, if we have to go deep into the burden of sickle cell disease, we might not leave it. It's a long story and a
It
lot,
is, it
lot,
is.
lot of story behind it. So I think we just keep that as it is there. So talking about bone marrow
Okay.
transplants, I want you to bring it down to a layman language. Can you bring it down? Like, what does
Yes.
this mean in terms of cure for sickle cell? What does it translate for us in the country? What does it mean?
What does it really mean? It means a lot. It means a lot because, if you talk to the people, common man on the streets, you go to the communities, rural areas. I like interacting with persons from rural communities. I want to get their understanding of diseases generally, and then of sickle cell. It used to be said that sickle cell, in this part of say is abiku in amongst Yorubas, or manje, amongst Igbos, that this is a disorder that a child comes and goes, it dies, or the child is born to die. And that's just because it's associated with short lifetime. Longevity is limited. In Nigeria, this is I have it here. The longevity of sickle cell disorder in Nigeria, they don't live more than 20, on average, 20 years. The lifespan of a person with sickle cell, 20 years. But that's an average. An average pools numbers together. There's some who have lived up to 90 years. We have on our board persons who are well over 60 years, 70 years, 80 years. So we have those numbers there. But in general, we know they don't live long, but they're doing better. When I was a medical student, sickle cell was considered a childhood disease. We didn't see them more than maybe maximum 10 years old. But now we're seeing them in later and later decades. So that's because of better treatment protocols everywhere in the world. And the thing is, most of this research is done in America. And then we now bring them to Nigeria. But I'm saying we should reverse it. If Nigeria is sickle cell capital of the world, we should lead in this fight, for on all efforts around sickle cell. We should be in the forefront of the fight for against sickle cell disorder. Our research, our treatments, and all that, which is why I'm glad that we now have our own bone marrow transplant center. That's as far as that's concerned. Now, bone marrow transplant center, it's a program itself or procedure, is not surgery. I had the fellow doctor who said to me, "Okay, who's the orthopedic surgeon you have on your team?" And I was taken aback. Orthopedic surgeon, and I said, "Okay." He's thinking that we're going to cut bone and transplant the bone. No. It's not surgery. It's not surgery, but a lot goes into it. Bone marrow is where blood cells are manufactured. If remember, if you eat chicken, the bone, that browny thing in the middle of bones, the long bones of chicken thigh, for instance. Do you know it? If I may ask? Because young people these days, they just eat flesh. They eat the chicken flesh and throw away the bone. In our time, we used to crack bones, So in the center of those long bones, you see the browny, gooey stuff. That is the bone marrow. And now the general term for this transplantation is stem cell transplant. Stem cell, and as the name implies, a stem can branch out to different things. So the stem cells for bone marrow, as they branch out to form red blood cells. If you remember your biology, I hope you do. We have red blood cells. We have which other cells? White blood cells, and we have platelets. There are 3 types of cells. The red blood cells are the ones that help you to carry oxygen around the body. The white cells help you to fight infection. The platelets help you to prevent bleeding to death. Okay. Now the red blood cell, that is where that's where sickle cell problem lies. The problem is inside a substance called hemoglobin that gives the blood the red color. The hemoglobin is what attaches to oxygen when we breathe in air. The hemoglobin in the red blood cell catches the oxygen and helps you to carry it around the body. Otherwise, one is dead. So the red blood cells are so important. So unfortunately, for persons with sickle cell, their hemoglobin is defective. So it doesn't carry blood around the oxygen around the body efficiently or effectively. And the red blood cells are shaped, wrongly. They're shaped like a sickle. That's where the name came from. Or like a letter C, or like a banana. And with that kind of red blood cell, you cannot carry oxygen around the body. And then the red blood cells die quickly. Whereas a normal red blood cell will live up to 120 days, 3 months in the blood. For those who have sickle cell, their red blood cells die off within 10 days to 20 days. And so the body has to replicate, rapidly. Wow. So that's a fundamental problem in sickle cell. And in bone marrow transplantation, you want to change that kind of cell. You don't want them to have that kind of cell anymore. So you look to who is a donor, and of course you've heard about SS and AA. SS is what we designate those who have sickle cell. AA are those who don't have sickle cell at all. AS, like myself, I'm AS, we're carriers of the gene. We can pass the defective gene S to our offspring, but we're not sick. We don't have the disorder, okay? So for bone marrow transplantation, our best donor will be someone who is AA. But you can still use AS. The worst that your patient can become will be your patient will become AS2, like the donor. But if you use AA donor, your patient will become AA as well. So formerly AA and SS now becomes AA. So the life is like night and day. The life is so different. If you interview those who have gone through the procedure and how their life has changed, they tell you that normally I have one person in mind now who said to me that I used to look at my clock every Wednesday morning. I'm supposed to rush to see the doctor, but I don't need to see the doctor anymore. I don't go there anymore. You only go once a year. And the life changes. No more crisis. No, life has changed. It's like night and day. And those who are children who were stunted, they become tall. They put on weight. Life is different. I'm jumping the gun. Let me dial back. The process is not surgery. We're not cutting bone and putting in. We're going to the marrow. I said marrow is the source of stem cells. But there are other sources too. You can get from what we call peripheral blood, from the vein. But if you put your needle in the vein and collect blood, you won't find many stem cells. Stem cells are primitive. The native, old, we call them primitive because like they're still in the early stages of differentiation. You won't find many. You'll find a few in the bloodstream. So what those who use this kind of source do is they go and give the patient drugs to bring out, to mobilize those stem cells from the marrow into the bloodstream, so they're able to pull it from the bloodstream. It's easier, it's cheaper, but it's not the best. It has not given the best results. We have gone for the best quality and the safest, and that is marrow. The marrow, you have to get a donor. For our protocol, we're keeping it very simple. We're using only donors that are your siblings. Same father and same mother, not your father, not your mother. You are 50% of your father, you are 50% of your mother. But you can get 100% from your siblings. You and your siblings share the same gene pool. So if we want a 100% match, which is what we do in our own protocol, in our own center, we don't do 50%. There are those in advanced who are advanced that can do 50%, but we don't do. We use only your brother or your sister from the same father and same mother. That's where we can get 100% match. So our two patients that I've just completed, both of them luckily had brothers who are AA and who have 100% match to them. There's something, a test we call HLA typing. Don't worry, don't mind the language. It's a big terminology. Just take it as HLA, human leukocyte antigen, HLA typing. We want to be sure that with that typing, the donor and the recipient are 100%. And that's what we had. And I believe God helped us definitely, but I believe because we had that kind of 100% match, it was easy for our patients to be quickly discharged. We thought our patients would be on the isolation ward for up to 30 days. But within 11 days, one was ready for discharge. By 2 weeks, the second one was ready for discharge. So they did very well in a short time. So the second match we also did was what we call ABO blood group, normal blood grouping. When you say somebody is a universal donor, somebody is a universal, we don't even talk about that anymore. ABO blood group. I don't know if you know your blood group. In case of accident, they say, what's your blood group? That's not SS and AA, mind you. It's different.
I know.
O
positive.
I'm O positive too. So that's one too, the donors and the recipients, they're the same. And we have this kind of matching on two parameters. You're not likely to have any kind of rejection, which is the problem with stem cell transplantation. Rejection of a graft, because your body is so used to itself to see anything that is not of self as foreign and mounts a severe reaction that can sometimes lead to death. So we didn't want any of that kind of wahala. We kept it very simple. Sibling donor, 100% match, ABO group blood type matching. So with that, our patients are out of hospital as you and I speak today. They've been discharged. So, and what is it? Well, I'm jumping again. The donor is one that feels the pain, has to go to theater, but it's not surgery. Take a syringe, a big syringe, under anesthesia. It can be local. Some people do local, but we did general anesthesia. The patient is asleep. And then you go to the hip. The hip bone is the best source of bone marrow in the whole body. There's bone marrow in your long bones, but the best source is the hip bone. So under general anesthesia, the experts, they call them those who actually draw they're hematologists, they're clinicians, but they've learned the art of drawing marrow from the hip bone. So they drew the marrow within 20 minutes. They collect enough. They collect enough marrow. Incidentally, somebody asked a very clever question. It's the medical student said, "Okay, if it's bone marrow, the bone marrow that I know is not liquid. How are they going to draw it with a syringe? But it is liquid under body temperature, normal body temperature. What you draw is like blood. It's inside the bone, but it is liquid like blood. So we draw it, put it in a bag, like a transfusion blood transfusion bag. That's what you will see. And then they hang it, but it's not direct. What we do, we will go through what we call the cell processing lab. And we take out any impurities. Sometimes it might be tiny bone particles, anything that is there that's not right. So in quality and in quantity, the cell processing lab does that job of giving you the best quality blood bagged, and that is infused into the patient. And over a period of a couple of hours, the blood is in the patient's body. And the way God has made us, is that it has the miracle of it all. The blood cells, those stem cells, they know where to go. They don't go to the brain. They don't go to the heart. They go to the marrow of the patient. But remember, before now, we'd have prepared the patient's marrow. We have given the patient some medication to clear the marrow, to remove the kind of cells that are there, because we don't want that anymore. But remember, when you do that, you open the patient to infection. Remember, I told you that white blood cells help you to fight infection. So as you wipe out the marrow, you are wiping out the white cells as well. So the patient has to be, what we really do is prevent infection, prevent infection. The bulk of our efforts after the infusion was to ensure that the patients were in isolation. Anybody that's going to see them is dressed like they're going to space, so you don't give them any infection. Even the room they're in is so equipped that the air does not flow out and air does not flow in. Even when you open the door, there's pressure that does not allow air. No, air does not mix. So because the greatest source of infection is the air that we breathe. So it's called HEPA filter system. It's air conditioned, it cools and prevents any kind of air from exchanging from that room outside or from outside into the room. Now it costs a lot of money to get that kind of room, that kind of machine and equipment. So so much goes into it. We prevent our patients from getting infection. And once that is done, and that was the case in our own, the patient was infused. Within a few hours, the marrow was inside the patient's own bone marrow. And in a couple of weeks, they're taken. So a patient that was SS is now AA.
Thank you very much for this explanation. You explained as if you were in a biology class, and there's no way someone will not understand this process. Now, how much does it cost for transplants?
That's very, very, very important, because I was telling you now that you see that room alone, the cost of that room to prevent air from coming, to set up the whole the whole center. I think I cannot give you the exact figure, but it set us back about ₦1 billion to set up our bone marrow transplant center. The equipment, everything is dollar-based. Equipment, that stem cell processing I talked about, it's good. You need to come and see the stem cell laboratory, to make it come to life for you. I'll explain to my team that we're still in the process of determining how much went into the components, the constituents of the entire costing.
Okay.
We still haven't got it as I speak to you, because we're forgetting many things. Okay, I told you now that the donor has to go to the theater and be put to sleep. We forgot that we had to pay the anesthetist that put the patient to sleep.
Well, on the average, is this something we can just put an average cost at?
I cannot give you, but I can give you the cost in America, which is where most of our patients who can afford it go. It costs between $250,000 to $1 million in America.
Wow. Excluding the flight ticket and everything.
Excluding. But see, ours, we have it here so that we make it available and accessible to our own people. So as I'm talking to you, we are already putting together a fund. Sickle Cell Foundation Nigeria is in this partnership. You know, we're not doing it alone.
Yeah.
The initiative is ours, but when they first came to us and said, "Oh, you need to employ doctors, employ hematologists, employ nurses, I said, "How are we going to do it? We're not a hospital, but we can collaborate, we can partner. Youth is just opposite us. I'm already working together with Luth in other areas. So we reached out to Luth as a technical partner. So the doctors, the clinicians, and the hematologists and so on that were part of this came from Luth. But we sent them to train in Vanderbilt University Teaching Medical Center in Nashville, in Tennessee. We sent them for training for bone marrow transplant in Nashville for a period of 6 weeks. And they came back to Nigeria ready to roll, even though we still have supervision from our technical partners in Nashville. So in the area, the era of doing things on your own have gone. If you do that, it will not be affordable. You have to work with people in partnerships. So Sickle Cell Foundation Nigeria is the centerpiece of this partnership. And I'm happy we've been able to pull that off. In terms of making it, like I said, some Nigerians can afford it, and that's fine. And we're getting a lot of inquiries, even from America, from those who can afford it. It's okay, but many Nigerians cannot afford it. So two things we're doing is doing the fund to support those who cannot afford it, so that even if they're going to make any payment, it will be minimal. Then also talking with state governors, the people who qualify for this transplant. It's not every patient who has sickle cell that qualifies for transplant program or transplant procedure. Many doctors will tell you, you better live with your sickle cell, they are okay. Because if you haven't had crisis in 3 years, why are you bothering with the transplant? Transplant is not a stroll in the park. We are keeping it very simple, but it's a very complex procedure, and people can die from it. Okay, in terms of, so someone also asked, okay, what's the success rate? With our own kind of system, it pushes it about 95% or more success. But that's because we are not even using parents. Those who use parents, pushes it down to 70%. If you use 50% matching, it makes it less effective. And at the end of the day, you wonder with some patients that is it not better to have lived with a sickle cell than to do this kind of okay. In India, it can be as much as yes, I got a figure from my colleague in India, $75,000.
Wow.
Again, that's without transportation, without room and board for 6 months. They have to stay there. Okay, minimum of 3 months. They have to stay there, room and board, hotel. I can't even add that, but that's a lot. But suffice it to say that we in Nigeria, Sickle Cell Foundation Nigeria, wants to make it accessible, affordable to Nigerians. And they were stepping in the gap by setting up this fund and also working with governors so that any indigent from any state will hold the governors to say, please pay for your indigent.
One interesting question I would love to ask. In those days, or pretty recent, we used to hear a story about people not getting married if your genotype doesn't match. SS and SS marry themselves again because if they marry, they will give back to another sickle cell again.
Sickle cell.
With this bone marrow transplant, is it advisable? Is it
no, I'm not going to. It sounds very simplistic to say so. It's still important. I'm happy to say that the federal government now is stepping up to the plate to come up with a policy for sickle cell control in Nigeria. And that includes what we call newborn screening. So every Nigerian, right from birth, the family at least will know that this child is AA, this child is SS, this child is AS. Oh, this AS, maybe if it grows up and wants to marry, they have to be careful who they marry. So from early on, before people start dating, in fact, we form part of their conversation when they're dating. Okay, so if they get into it, going into it with their eyes open, but they still have to come for what we call genetic counseling. Okay. Genetic counseling. In our center, we offer that every day of the week. But genetic counselors will not force you not to marry somebody that you are in love with. There was a lady who came to us not too long ago. She brought her fiancé. They were angry with us because they felt we were imposing on them. But that wasn't the case at all. We're not imposing. We're just giving them the facts. But you make up your mind yourself. They felt they were going to marry no matter what anybody said. In fact, they had been sent by their church, one of the Pentecostal churches, that the pastor will not marry them except they come with the certificate that shows that they're compatible. And I said, okay, what is compatible? They said, okay, it means they must not be AS and AS. I said, but you're AS and AS. They said, okay, well, that's why they come. Yeah, they said you should come for genetic counseling, but they're giving you all information so that you make up your mind whether you still want to marry each other or not. Okay, if you want to marry each other, we'll tell you what options are available to you. Options include what we call prenatal diagnosis. That is, you can determine the genotype of your unborn child in early pregnancy. We offer that in our center. So within the first maybe 9, 10, 11 weeks of pregnancy, the couple can say, okay, this child is SS or AA. So people now ask, to what end? So I was looking at data from over about 30 years now since the program started in Sickle Cell Foundation Nigeria, when they started this prenatal diagnosis. At least for the first 20 years, almost every couple that they found their child, the unborn child to be SS, they went for abortion. Others will not answer. And once they don't answer, they know that they went for abortion. Okay, so we consider it a form of early diagnosis, because early diagnosis is so important. When you diagnose somebody with SS in time, do you know that you can prevent those infections that kill these children before the age of 5? Because we give the data that 150,000 babies are born every year in Nigeria, 150,000 annually, out of which more than 100%, more than 100,000 die before they turn 5. And what kills them is infection. Again, infection, you know. But if they know, like that prenatal diagnosis, a couple knows before their child is born that the child they're carrying is SS. As soon as the child is born, we take them under our wings and we start them with what we call preventative measures. We give antibiotics, penicillin V prevention within 2 months of life. So they won't even have those infections at all. Normally, when a child is born with the sickle cell, you can't tell the difference between that child and any other child. They're bouncing baby girl, bouncing baby boys. Only around the age of 7 months or 8 months that the child with sickle cell begins to show. Because by then, the protective hemoglobin that the mother gave the child is waning. And then the child's own genetic makeup begins to show. But that's when you start having the symptoms. But by that time, it's a bit late. By that time, they'll be having crisis, and then it becomes difficult to look after the child. So early diagnosis is so important. So we in Sickle Cell Foundation, we take that prenatal diagnosis as a form of early diagnosis. So before the symptoms begin to show at all, we start with antibiotics. We start with progranil, all the things that prevent. You won't even know that you won't know that they have sickle cell. So that's a way to take care of them. It's what I call bone marrow transplant. It's just the apex of the pyramid. It's only those who can afford it. Very few people. But the most people are the base of the pyramid. The base of the pyramid, you give them folic acid every day so they can they can manufacture blood cells. You give them antibiotics every day to prevent infections. And you give them anti-malarials every day to prevent malaria. Once you do that, there'll be no crisis, I tell you. And then they also follow the do's and don'ts. Take care of themselves, and they can live a normal, productive life and contribute meaningfully to their communities. I think as a public health physician, I would say that base of the pyramid is very important. The apex, bone marrow transplant, is good to have. It's a good to have, but that should not form the basis or the middles of our sickle cell control.
Thank you very much for your time. I do appreciate this time with me. I don't know if you have any last word or any parting word you want to say before we call it a day.
Well, I always have many parting words, but I think for one thing I would say still is that, government, I would say thank you for coming up with the newborn screening so that Nigerians will know where they stand as far as their genetic makeup is concerned. So early enough, every Nigerian will know, how to end, whether they're going to marry, when they're going to marry, they go in with their eyes open, as it were. So that is not enough. The government still has to do more in form of supporting the sickle cell cause. So that's my call is to government to do more than they're doing now.
Thank you so much for your time.